Good afternoon and welcome to HIT Policy Update, a webinar tweet chat combo from healthsystemcio.com, sponsored by GE Healthcare. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the editor-in-chief of healthsystemcio.com, and I'll be your moderator today. Our managing editor and director of social media, Kate Gamble, is hosting a tweet chat during this event. You can view it in the media viewer panel on the right-hand side of your screen, and you can participate in a separate browser or on your phone by using the hashtag HSCIO chat. We'll also be using the polling panel today as a new feature of our policy update webinar. It'll open automatically when we launch the poll. And if you have questions during the event, go ahead, type them into the Q&A box and send them in. Leave the default set to all panelists, and we'll take those later in the program. And you can download the deck using the URL on your screen. It's at the bottom of the slides, and it will be sent out in the chat box. Just so you see how we're going to spend our time today, first we're going to look at those polls, get you to answer them. Then we're going to hear from Dr. John Halamka, CIO at Beth Israel Deaconess Medical Center, for our main presentation. Then we'll hear from our sponsor, represented by Tom Zimmerman, Senior Regional Product Marketer for the U.S.-Canada region with GE Healthcare. Then we'll take a look at the poll results, and then we'll have our Q&A. So, our first poll question, and let me go ahead and open this poll for you, and you should see that on your right. So you've got two questions here. The first question, and this is a single select, what will be the biggest leap forward for interoperability during the Trump administration? And these were provided by Dr. Halamka, so he's interested in seeing your results and then discussing them at the end. New and better standards and national healthcare identifier, uniform privacy and security laws, less federal enforcement of regulation, giving the private sector more time for innovation, or disruptive consumer technologies. So that's question one. Second question, are you continuing your preparation for macro MIPS and other Obama-era programs scheduled to go live in 2018? Yes, full steam ahead. Yes, but we're working slowly, remaining agile for likely changes ahead. We have not decided yet. No, we've allocated budget but are not doing anything until we see a definitive policy statement from the new administration. Or no, we believe all Obama-era HIT regulations will be eliminated. So again, we're going to leave that poll open for a few minutes. Please, everybody, go ahead and answer it, and we're going to look at that later in the program. So without further delay, we're going to turn the presentation over to our good friend, Dr. John Halamka. Dr. Halamka, thank you so much for once again joining us.
Well, Anthony, always a pleasure to be here. And here I am in New England, a traditional blue area of the country. And, of course, I say to my friends, the election result was surprising. See, that way I don't commit that I thought it was good or bad. It was just surprising. So I've learned my lesson. What I thought would be interesting today was to actually reflect from our last HIT policy update what I thought the election might bring, because hindsight is 20/20. We'll see how I did. And then we'll actually go into what, now that we have a Trump administration coming, what that is likely to lead. And then I'll reflect on some of the things like 21st century cures and what I see as the imperatives of the next couple of months ahead. So, Anthony, if you remember, what I said the last time is, whether it was Hillary or Donald, recognize that politicians come and go, but career people in government are forever. And that is, do our congressmen really make the laws? Well, they vote on them. But it's the staff that really create the verbiage. And I think the same thing is true in executive departments. So even though we will see the wholesale resignation of all the political appointees in the Obama administration, January 20th, the career people are going to persist. So interesting. Now that we have Trump, I mean, sure, you know, as we'll go through with Tom Price and Irma Verma and some other appointees, you may have some change in overall direction, but those folks that were charged with implementing Obama-era programs like value-based purchasing, they're still going to be there. Yes, Vendel Washington, our national coordinator, will exit, and I imagine a career person such as John White, who in the office of the national coordinator is the deputy and is a career guy, will step in until there is a national coordinator nominated. I mean, of interest, and certainly, Anthony, you're a journalist, so I'd love to get to your feedback on this. I actually haven't heard one way or another if the Trump administration wants to bring in some new talent to the national coordinator function, grow the national coordinator function, shrink the national area coordinator function. Just haven't really heard about that. So I imagine John White will be our interim until action is taken. I predicted that MACRA, it may be slowed, but you're still going to have continuity of those folks who have to move us to value-based purchasing because there isn't a credible alternative. I mean, we're not going to just continue on the fee-for-service, charge 17 to 18% of the gross domestic product forever treadmill. And certainly, I think I have seen, and I continue to see, that payment reform in healthcare is bipartisan. So I think the good news is, as we look at our September conclusions, those are probably still true. But what can we say now more definitively, now that we have Trump elected president and confirmed by the Electoral College? Trump and his appointees, in general, have said regulatory burden must be reduced and tax burdens must be reduced. Okay, so you could imagine that, as I said in the poll question, could lead to the private sector having more time, more money to be able to innovate. Could be that the economy, because there's less going to taxes and less going to higher compliance and regulatory people, may see more products and services introduced. R&D spending may go up. Could be. We'll see. You might see more free market competition, because in the past we've had regulatory prescriptions of what it is we had to do. And, whether you argue about meaningful use stage 2 as good or bad, I mean, what you could say is it was very prescriptive. This is what you must do and how you must do it, as opposed to here is a policy outcome we want you to achieve, and let the market innovate to create products and services that doctors, nurses, pharmacists, et cetera, wanted. So it could be that as we see some regulations diminished, there could be free market competition to get better usable solutions that reduce the burden on clinicians. You might even see some of the what I'll call long-standing cross-aisle arguments about such things as should Medicare be able to negotiate drug prices. Maybe some of these arguments will dissipate. Maybe there will be more ability of some aspects of government to function in a free market kind of way. You, I think, probably know that Apple has billions of dollars offshore, and much of that money was placed there because of unfavorable tax consequences in the United States. In fact, Tim Cook has said, should he repatriate the funds from overseas, it would cost about 40% in tax burden to repatriate those. Trump has signaled that you might see maybe a 10% tax rate on repatriated funds. So maybe some will come back to the United States, again, making more capital available for innovation investment. You hear a lot of rhetoric about the Affordable Care Act, Obamacare, being eliminated. But yet, if you look at the detailed proposals, there's a whole lot of the Affordable Care Act that would stay in place. The idea that your 26-year-old child could continue to be on your insurance program, or the idea that pre-existing conditions would still be covered by law. What probably will change is the health insurance exchanges will be reshaped in some way. I think it was a bold experiment, but what we found in health insurance exchanges, we expected that young, healthy people would sign up in droves to fund all the health care of those who are not so healthy. What we actually saw was sick people signed up, young people said, take the penalties. They didn't work completely well. They may very well just wither on their own. So this idea that there would be a public option, that there would be more of what we would call a sort of socialized medicine kind of approach to delivering health insurance may not come to pass. You can expect in general that a lot of federal authority will be ceded to the states. A lot of federal programs move to the states. States will have their ability to have flexibility and create programs and services that are more appropriate for their populations or regions. So you might see Medicaid, for example, become block grants to the states, and therefore it could be that some states like Massachusetts be given a block grant and can do innovative IT things with it, because our state has always thought that investing in IT improves quality, safety, and efficiency while reducing cost. So that's interesting. One thing that could come of that, however, is each state is now given its own freedom. You could see chaos. You could see a Tower of Babel as we have 50 different programs and standards and data requirements and quality measurement mechanisms if we truly remove all of this stuff from central coordination to more local coordination. So there could be a downside. It's hard to know what will happen to FDA oversight, but as we'll talk about in a minute with 21st century cures, it may very well be that you'll see pharmaceuticals and devices come to market more quickly. There'll be alternative mechanisms other than clinical trials to evaluate their efficacy and safety. And so you could imagine a framework where both the FDA and the FTC have less regulatory enforcement, and that again gives the marketplace a chance to get products and services to that marketplace more quickly. I think the counter-argument will be, do we get them to market before they are convincingly safe, and may that create a lot of harm. So we'll see. I mean, I looked to what Bill Maisel did at FDA last year in creating a framework for mobile apps, where he said there are three kinds of apps. Those that are more of an administrative nature, don't regulate them. Wellness, how much should you run? How much should you eat? Your risk of harm pretty low, don't regulate them. The app that takes a selfie and decides you're pale and therefore have cancer, of course, that would be regulated because it's diagnostic and therapeutic. It could cause harm, right? It's a risk-based framework. So we might see more of a framework rather than regulatory enforcement. Could be. So here's the bold prediction, and we'll talk about Tom Price in a second, that the idea of value-based purchasing, of pay for quality and outcomes, has to persist. There's just no way our country can maintain its economic competitiveness around the world if we're putting 17 or 18% of the GDP into healthcare. And there isn't a credible alternative to value-based purchasing, alternative payment models, so it may be delayed. You might, yes, see the regulatory burden on clinicians diminish, quality measures restructured, but the idea of moving to value-based purchasing and the tools to support value-based purchasing will continue. And that means from a healthcare IT perspective, you might need something like customer relationship management. How do you treat the patient as customer? Keep them healthy in their homes. Identify those who are at high risk for developing disease next year. Keep them well by putting resources in their homes. Our EHRs today are mostly designed to record an encounter and send out a bill, as opposed to keep a population healthy. So I think since value-based purchasing trends will probably continue, although they may be slowed, but they will continue, you'll still see a need for completely different software applications to support care management and telemedicine, telehealth care in the home that's different than the EHR today. What about precision medicine? Well, again, this one's a little bit dicey to predict because Cancer Moonshot, Precision Medicine, the Center for Medicare and Medicaid Innovation, CIMI, those are all programs that were funded either previous to 21st Century Cures or funded in 21st Century Cures. But there is an interesting aspect to 21st Century Cures as legislation, and that is it requires annual re-upping of funding. So I think the people who looked at this critically thought, that's interesting. We're funding the Cancer Moonshot for a year, and then a year from now we have to come back and decide if we want to continue funding it. That may not be the greatest way to sustain a program if you're not even sure if your funding will be there next year. So therefore, you might imagine that some of these programs from the Obama administration may see diminished funding over time when their funding that's already granted runs out and won't be renewed. and specifically Tom Price, has not particularly liked the Center for Medicare and Medicaid Innovation trial programs to look at alternative payment models. So that, certainly something to watch. So let's look at these new players. And so I'm sure you guys have all read Tom Price's various opinion pieces that he's written over the last 10 years, the various kinds of legislation he's filed. But capsule summary, so Tom Price is a 6-term congressman from Georgia. He's chair of the House Budget Committee and a leading healthcare policymaker in the Republican Party. He does work well with his coworkers. He's not seen as too disruptive. But fascinating, he's both a doctor, an orthopedic surgeon, and a politician. And he often, in his writing, has tended to side with doctors, not politicians, and has contended that regulatory burden disrupts the provider-patient relationship, and overly prescriptive regulations take the joy out of healthcare. And certainly in the Meaningful Use program, we've now seen 50% of doctors claim they want to leave the profession of medicine because they are no longer practicing at the top of their license. So yeah, he's probably right that we have to really reflect on what we've done to the doctor-patient relationship and recast who does the work and what is the nature of the work. In 2009, Tom Price did file a bill that was his alternative to the Affordable Care Act, and in it he suggested tort reform, mechanisms of reducing lawsuit burden in general on physicians, but also giving physicians a bit more flexibility in the way they charge. So, very physician-centric approach. You look at his writings on MACRA and MIPS and quality measures, and what he suggests, and maybe again he's correct, we have so many quality measures, and some of those quality measures don't necessarily reflect appropriately the strengths of the practice. One that I would just give you as an exemplar, I have glaucoma, and yet my ophthalmologist is measured on smoking cessation counseling and blood pressure control, as opposed to my field of vision, my visual acuity, and that sort of thing. So I think what you're going to see Tom Price suggest is slow MACRA MIPS. Keep it going, but reflect on the process measures that are going to be better aligned to measure the strengths of a practice. So probably we'll see a very significant revision in the way quality is measured, and I expect as well he'll work hard to reduce physician burden. So he'll lead HHS, and working for him will be Irma Verma, who will run CMS. And if you read her writings, most of what's coming out about Irma Verma is related to the work she's done with Medicaid in Indiana. And yeah, I think even her critics say that she's expanded Medicaid in Indiana, covered more people, therefore there's more insurance and stop-loss coverage for catastrophic illness, and all that's good. The controversy is she's created the notion of a premium, and that is even if you make under $16,000 a year, you are still expected to contribute some amount to your health care coverage, less than 2% of your income, but still some amount. And the reason I suppose it's controversial, suppose you make $16,000 a year, you've just suffered some catastrophic illness, been diagnosed with cancer, run over by a car, you miss your premiums and your health insurance disappears. Her logic was that people will only value health insurance if they have skin in the game, and therefore everyone should make some contribution. But the downside is it does seem to be a bit onerous if suddenly at a time of need your health insurance is no longer available. So we'll see what she does, but I suspect she'll focus on Medicaid expansion and potentially the idea of premiums that will be contributed by patients, all patients. Healthcare IT influencers. Now, this is where I said I'm a little bit in the dark on this one. You look at the Obama administration and you ask, who are the usual suspects who staff committees and who are counselors to the president or to folks at OMB or HHS. And there's a cohort of very well-known academics and industry leaders. I have yet to see a clearly identified cohort of nationally known healthcare IT influencers advising the Trump transition team. And so, of course, my phone has not rung. I have not been called and asked to, but none of my colleagues have either. And so, again, I just think we should watch this because clearly the policy direction will be materially influenced by the experts that are brought in. And so let's see who those experts are. I mean, we know Tom Price, we know Irma Verma, but haven't seen IT experts specifically. Well, let's take a look at 21st Century Cures. So 21st Century Cures, 1,000-page legislation that focuses on many things, mostly accelerating pharmaceutical and device introduction to market, but it has quite a few IT provisions. And Anthony, as a service to the listeners, on my blog last Wednesday, took the 1,000 pages and distilled it to 2 that you could read, telling you about the healthcare IT impact of 21st Century Cures. And there are a few things. It eliminates the policy and the standards committees, these federal advisory committees that have helped shape HIT policy and the technology, and replaces them with a single committee called the Health Information Technology Advisory Committee. Again, not totally clear who's going to be on that advisory committee, but when you look at its charter, it is interesting that it tends to focus a bit more on interoperable standards and the role of data exchange than just policy in general. So fine that there's one committee. I mean, admittedly, it was a bit unusual to have the policy committee of the Obama administration suggest the path forward and then pass it off to the standards committee, only to discover that no standards for that path forward existed. So with a singular committee, you might see unification of technology and policy, but more of a technology focus. And we'll see in upcoming months who's appointed. You see in 21st Century Cures this need for application program interfaces and for vendors to make the data widely available from their EHR. So there's specific language against information blocking, and I've certainly debated whether information blocking truly exists. I've said that there's incompetence and there's lack of a business case, but I've rarely seen somebody competent specifically block information exchange when there's a business case. So it has penalties for information blocking, requires the vendors to open up their products, and the language is a little vague, suggesting that the vendors have to open up every data element for every purpose for every stakeholder, and that could be an interesting burden on our developers and vendors. It also suggests that EHR vendors must contribute to registries, and although that's goodness, the problem is that once you've seen one registry, you've seen one registry. And so EHR vendors are going to be committed to contribute to every registry. It could be a nearly infinite amount of work. So I look at 21st Century Cures as, there's nothing that egregious in it, but we have to be very careful, because if our vendors and developers are spending their entire next 2 years on just congressional mandated initiatives as opposed to customer requested initiatives, we could see a lot of dissatisfaction. And just in speaking with one leading EHR CEO, he said he anticipates just from MACRA and MIPS and everything that has been proposed to date, something like 600 man-years of work on regulatory and legislative issues, which really prohibits them from doing that much innovation that is informed by customers. So tips on surviving the road ahead. Again, none of us have perfect vision of where it's all going, but I think we can say, looking at Tom Price and Irma Verma, looking at value-based purchasing, looking at the incumbent staff, we all still need to work on quality and safety and efficiency, reducing burden of clinicians, making sure the products we introduce are safe, and that we are going to measure some kind of outcome or process that will still be used as part of reimbursement. So start thinking about customer relationship management and care management, medical records and decision support and things that would help you get to this new world of reimbursement. I think you're going to see Tom Price and others argue that we should spend a fair amount of time on usability, that existing DHRs have too many clicks and the doctor's doing too much work. So probably you can predict we're going to get new products and services, maybe even overlays, maybe apps or modules that sit on top of our EHRs that enhance usability, reduce keystrokes, and make clinicians able to practice more at the top of their license. Yeah, and I think we can be fairly confident that fee-for-service will wane. It will take years, of course, but still, we are headed in a direction where fee-for-service will be less important going forward. Remember, although when Donald takes office in January, he could immediately do some executive order reversal, but regulation writing, it takes time. So maybe in the first year, you'll see sub-regulatory guidance or regulatory revision. And even with Republican-controlled House and Senate and presidency, legislation just takes a very, very long time. So I tell people, don't expect a revolution. Expect an evolution. And I think it's going to be more thematic and selective. You're going to see a lot of the Obama-era stuff still percolating for several years. But what I also feel is that just as the last 4 or 8 years were led in many ways by the Office of the National Coordinator and CMS and government initiatives, you might see that the next 4 years will have initiatives led by the private sector. So we'll see organizations, companies, and NGOs, folks who are working on interoperability solutions, Commonwealth, and care equality, and those sorts of groups probably leading the charge more than government will lead the charge through a top-down kind of approach. So that, Anthony, is my synthesis on how healthcare will be great again. And
awesome.
I will turn it back to you.
Very good. Well, thank you, Dr. Halamka, for that informative and always entertaining presentation. I just want to remind our audience to go ahead and send in any questions you have in the Q&A box. Leave the default set to all panelists, and we'll take those in a few minutes. But first, we are going to hear from Tom Zimmerman, who is representing our sponsor, GE Healthcare. So, Tom, thank you for sponsoring, and we look forward to your presentation.
Thank you very much. My name is Tom Zimmerman. I lead marketing for GE Healthcare Digital and Enterprise Imaging in the United States and Canada. We're really pleased to be part of your program today, so thanks for including us. You know, like all of you, we're seeing and we're experiencing this shift to more patient-centric care, and more than ever, I think the healthcare industry sees information technology as one foundation on which to build your collaborative care networks. So I'll just take a very few minutes to talk about that today. GE Healthcare is continuing to invest and grow in these integrated care solutions, and ultimately this is meant to help you and your teams produce better clinical, financial, and operational outcomes. So at GE Healthcare, our imaging solutions encompass visualization, workflow, archiving, and collaboration. And let me just share some brief updates as we head into 2017. So first, we continue to be very focused on outcomes, as I know you are, and there are real savings available when we can eliminate data silos with robust vendor-neutral archives or reduce duplicate messaging by accessing images from another enterprise without having to ingest or duplicate data. So our Centricity Universal Viewer, just as one example, can do just that, see and stream images from other PACS systems, even matching patient MRNs from your most recently acquired site. So just an example to say that this all makes significant productivity and patient care enhancements possible. So we've also introduced our first cloud-based subscription on the GE Health Cloud this year. When it's appropriate, we think the cloud can help you connect affiliated and unaffiliated clinicians to collaborate on improved care and efficiency. So the Centricity Collaboration Suite is part of GE's ongoing investment and commitment to the healthcare Internet of Things, and I'm sure you've read and heard about that. It's where we all help to connect people, data, and machines. And there are real examples of that now coming forward. One of the reasons we're all so interested in data, and I know you are, is to unlock that rich actionable insight that's made possible by having these advanced algorithms under development. And so as I close, because I'm just taking a few minutes today, but just an example of that, for example, Johns Hopkins Hospital recently launched a command center, and GE Healthcare helped to participate in the Judy Wright's Capacity Command Center and with the design and building of that. I encourage you to read more about it on their news release and how they were able to reduce dispatch time, improve discharge speed, and reduce transfer delay, just as some examples. As we are also looking ahead to partner with other thought leaders to dive deeper into learning and analytics. We're very excited to announce new partnerships this year with Boston Children's Hospital and University of California, San Francisco. And in the coming years, we hope to share much more on these deep dive algorithms with all of you. So I'm closing, and I think I am getting under my time correctly here, Anthony. We really do continue to like to help you teams achieve desired outcomes and do that across your enterprise so that you can increase patient satisfaction, clinical excellence, improve operational efficiencies, and of course have long-term sustainability. So thank you very much for your time today, and please do reach out to me personally or your local GE Healthcare Digital representative if you've got any questions. Thanks very much, and back to you, Anthony.
All right, Tom, thank you so much for the presentation and for sponsoring. Now we're going to take a look at our poll results and have Dr. Halamka reflect on them. So if we look in our polling panel, you should be able to see the results. Dr. Halamka, can you see those results, or should I read them to you?
I can.
Okay, let me know what you think.
Okay, and unfortunately the questions are a little bit, oh, I see, and now I can see them side by side. So what we see is the majority, what will be the biggest leap forward for interoperability during the Trump administration, and we see the winner is less federal enforcement of regulation, given the private sector more time for innovation. Well, woohoo, because that's what I thought too. And of course, the other folks in Area B, I failed to mention that in 21st Century Cures, among other things, it does authorize the GAO to do an investigation of the feasibility of a national healthcare identifier and understand the issues. So we will, for the first time in the Trump administration, see discussion of the national healthcare identifier. So I think those two are right on. You have a great audience.
Hey, we're not just letting anybody on the line here.
There you go. Are you continuing your preparation for MACRA MIPS? And see, isn't this fascinating? That now E is cut off. What is the percentage on E?
E is 2%.
Yeah. Okay. There we go. I see it scrolls. So fascinating. And people like me agree that the future of value-based purchasing, of quality measurement and a focus on outcomes, is where we've got a lead. So yeah, fine. It might be delayed. The quality measures might morph. But the policy outcome of moving to value-based purchasing is still going forward. So full steam ahead, or yes, with a little bit of agility, is, I think, the right answer. So wow, those poll results came out exactly aligned with where I think the Trump administration is going.
Very good. So our crowdsourcing has reinforced your opinions and given you confidence, even more confidence in them. Let me start off, and again, go ahead, send in your questions, and we've got one in, and we'll get to it. But let me start off by asking you, so 47% say less federal enforcement of regulation, giving the private sector more time for innovation. That, in addition to some of the other things you said, and not getting into politics here, but it sounds like positive stuff to me. So just your thoughts on that. You seem to have an overall positive evaluation of what's coming down the pike from our point. Let's just look at our narrow point of view here.
Well, so Anthony, what I tried to do in the presentation is be bipartisan and non-judgmental.
Right.
So you know, as you say, we're not playing politics here. You probably know I am the eternal optimist. And what is the definition of an eternal optimist? Well, for Christmas, you got a box of manure, and you say, there must be a pony around here somewhere.
Right.
So there you go. In that spirit, I'm looking for the pony. And so hence what you could conceivably say of the last 4 years, we had 21,000 pages of new healthcare regulations with 43 final rules related to healthcare. It's so dizzying. No one can comprehensively understand the implications of every one of those final rules. And in fact, sometimes the rules are contradictory. What often happens, and I talk to some policymakers about this, is that in the final rule, you make a compromise, but the problem is that compromise actually now offsets something else in the 1,000 pages that you didn't intend. And so what you end up with is a lot of contradictory rulemaking. And then you've got a regulator who says, well, what do you mean you didn't understand that there was the 3 midnight rule for part-time anesthesiologists working in federally qualified health centers that have 1 leg and 2 blue eyes? You know, it's like, oh, God, I forgot. And so what you hope is that, of course, you want to reduce fraud and abuse. That, you know, clearly we should focus on. But to penalize people because they didn't understand some footnote in 21,000 pages of regulations seems punitive. So,
right,
yeah, I'm being
to
bipartisan here. It's just saying let's focus on the themes as opposed to the details. Let's focus on the forest rather than the twigs.
Right, right, and we have to remember these people have full-time jobs, and we can't make complying with regulations another full-time job for them. Make sense?
That is true.
So, okay, let's go to our first audience question here. Can you give additional thoughts related to ongoing focus on continuing of care, meaning more episodic payment, resulting in further private initiatives related to interoperability and patient and family engagement?
Sure. So I look at just the Boston area, and there's technically competent people who are working very hard, and in some sectors we have a lot of interoperability. So for example, the reporting of data for public health, immunizations, reportable labs, syndromic surveillance, huge volumes, 97% compliance. And why? Well, it's a locally enforced regulation. It's not that hard. It's seen as a public good. There's a business case for doing it because you're penalized if you don't do it. However, how about the sharing of summaries across competitive organizations for transitions of care? Not happening so much. And why? Well, we could do it technically, but there, at the moment, isn't a business case in the fee-for-service world to have care coordination across all these competitive entities. Well, suddenly, if you start paying for outcomes and quality, that redundant MRI or that unnecessary lab test becomes a cost, not a profit center. And so suddenly you have the economic motivation to share data more often than ever before. And sometimes that will be provider-to-provider sharing, but as the question suggests, sometimes it will be provider-to-patient sharing. The patient, as the steward of their own data, will become more common. And certainly that helps with addressing privacy issues. You know, each state has its own privacy regs, but OCR has told us, if you send the data to the patient and the patient decides to share it on Facebook or Twitter or whoever, no issue whatsoever. So we'll probably, as we're now paid for more care coordination activities and outcomes, share more data in more ways than ever before because we are incented to do so.
Very good. Back to the poll quickly. A lot of people answered, the majority were yes, full steam ahead, I believe, but a lot of people answered yes, but we're working slowly, remaining agile for likely changes ahead. Does the working slowly concern you at all, or do you think really you need to be full steam ahead?
Yeah, I mean, so I was chatting with a hospital CEO a few days ago, and I was saying, we got this macro MIPS thing coming. He said, yeah, that's not coming until 2018. Why work on it now? Well, wait. If it's going to go live in 2018, you better have a year to prepare the software, the training, the workflow to get ready for 2018. What I think everybody senses, you see the word delay, delay, delay coming out of Congress, coming out of some of the new appointees. It may not be an effective date of 2018, maybe 2019. And there may be, as Tom Price has said, different quality metrics. So this is where you don't want to do throwaway work. So we absolutely want to stay focused on getting it done, but do the sorts of general things I described. Figure out how you're going to do customer relationship management and care management and risk adjustment and that sort of thing, recognizing in the next year there'll probably be some more clarity on some of the finely grained details of quality measurement and what needs to be certified and when it needs to be certified. So I think doing it, but leaving a little of the work until we have some clarification is actually a prudent approach.
Very good. One of our good friends, Drex DeFord, has commented that your points dovetail nicely with a webinar we have coming up in January, exploring open notes and how that can be instituted. And I know you're close to that project, aren't you, Dr. Halamka?
So yes, it started at Beth Israel Deaconess, and the interesting thing about sharing notes with patients, a lot of mythology, right? If I share a note with Anthony that says, Anthony, I think you are a manic person, not depressive, just manic. And you say, no, I'm just excitable. Well, we should have that dialogue, right? And that is, it doesn't lead to doctor-patient friction. What it leads is to doctor-patient conversation. And then we mutually agree. Maybe my definition of manic is different than your definition of manic. And we both decide in our, that we're both right. Or maybe I changed the note because it reflects a misunderstanding. Or maybe you just drink too much coffee. Who knows? But this idea of fostering dialogue results in a stronger doctor-patient relationship. It has never resulted in a bad outcome. In our years of doing it, it has never resulted in bad news being shared inappropriately, and it actually has reduced malpractice assertions rather than increased them. Transparency is often seen as very positive, even if the outcome isn't what you wanted. So yeah, can't say enough good things about that as part of your patient-family engagement strategy.
You mentioned that you haven't heard any outreach from the incoming Trump administration. Is that something you would have expected by this point, or do you think that may come down the road from perhaps people that he's working on appointing right now, and that they would in turn reach out? It's sort of a level type thing, getting down to that level of healthcare IT.
And I think that's exactly right. So in the Obama administration, healthcare IT was really a top agenda item. And that was because there was this bend the cost curve, reinvest in companies, help the economy turn around, all these other things. So it was a key platform element. So yes, it happened early. Whereas it seems like healthcare IT, although important in a bipartisan way to reduce costs and improve quality, isn't at the front burner. I mean, there are other issues that are being percolated first. So as you say, I suspect appointments will be made, they will take office, and then you'll see some outreach come the first or second quarter of next year.
And for those who feel they could be helpful, is it just a matter of sort of sitting back, or is there any proactive way to say, hey, I'm available?
Well, I actually think it would be useful to write articles now about, well, Tom Price, what is it that we've learned from the last 8 years or 12 years, and therefore, what might you focus on? And so I think my role, again, I've not been asked to serve in any capacity, but I will continue writing over the next 60 days top 10 lists of maybe some of the things that the next administration should focus on, and hopefully that'll be helpful to frame the issues.
Very good. Well, we look forward to reading those articles and and publishing them and helping you get the word out there. So I think that is about all we had time for today. When we close out our window here, you're going to be taken to a post-event survey. If you could take a moment and answer that, we'd appreciate it. I want to thank our speakers, our good friend Dr. John Halamka, and our sponsor, GE Healthcare, represented by Tom Zimmerman. Thank you so much, Tom, for participating today.
Thank you.
For those of you who have continuing education interest in today's event, Chime CHCIO gets you 1 CEU towards that program. So go ahead and let Chime know you were here, and if not, we will. And if you need a certificate of attendance for another CEU program, you can use the final slide. You'll get an email when our archive of this event has been posted to our YouTube channel. Sponsorship opportunities, for if you'd like us to create a webinar for you, you can contact Nancy Wilcox, and you can go to our website to view our upcoming schedule. So once again, I want to thank Dr. Halamka, Tom Zimmerman, GE Healthcare, and our attendees. Everybody have a wonderful day. Thank you.
Thank you.